Hello and welcome to our first module in disease management. This will be over COPD. The first thing to look at when you're managing COPD is how is it diagnosed? Most of the patients that you'll actually see in the hospital are not typically diagnosed. It is placed on them by a physician, usually in the emergency department, that looks over the patient and suspects the patient has COPD, and that's how the patient typically gets a label, but that's actually not the proper way of diagnosing COPD, which makes it one of the most underdiagnosed diseases in the healthcare system. The true indication or the true diagnosing of COPD first starts with a pulmonary function test. A lot of these pulmonary function tests look at before and after the use of bronchodilators to see if they are effective for the patient in treatment. They look at your forced expiratory volumes, FEVs, and things like that, and that is a really good indication of diagnosing COPD. From there, you would look at things like ABGs. ABGs on COPD patients, depending on how aggressive it is, could tell you that they are maybe a CO2 retainer. If they are a CO2 retainer, they would have a high CO2 at baseline, greater than 45, and a high bicarb, because the bicarb auto-corrects to move the patient's pH back into a normal range and doesn't leave it acidotic. And that would be in a long-term COPD situation. Another way that we can see COPD is on a CT scan or an X-ray, so with imaging. One of the easier diseases to diagnose is emphysema on X-rays, which I have a picture of to the right. You can see that the lungs are overinflated, which makes a barrow-chested patient. Emphysema is very easy to diagnose on X-ray because it's so unique compared to any other X-ray, where the patient traps air and pressure in their lungs continually. Over time, their airways distend and they hyper resonate their lungs, which means they have a lot of air. Air is black on X-rays, and there's just a lot of black lung field to their lungs. Another characteristic is real sharp diaphragmatic angles. You can see that at the base of the lungs, and you can see how tall the lung fields are. This is very big, elongated lungs. And one of the last common themes with emphysema X-rays is the distance in between the rib cages. So those are spaced out due to the long-term barrow chesting and the air trapping. Another way COPD can be diagnosed is through a lab test, especially an alpha-1 antitrypsin COPD. So that would be, blood cultures that the doctor would order. The patient would get collected, and we would find out through these. Typically, though, you need true diagnosis through one of these fashions to actually call a patient or say they have COPD. When starting to look at COPD, it is important to understand that there are 5 different disease processes that make up COPD. Students typically remember these diseases with the acronym CBABE: cystic fibrosis, bronchiectasis, asthma. Usually it's chronic bronchitis, but to remember it, we call it bronchitis, and emphysema. These 5 diseases, we could individually, and we will individually, go over each one of them. Looking at COPD management in general is one module. As we go through the course of this class, we'll go through these individually. They all have very particular aspects to them that are diagnosed and managed in different ways that I will touch some over in the rest of this PowerPoint. But they make up COPD. So a lot of people think that COPD is just a disease in itself, and that's all it is. And the more they study it, the more they realize that it's actually 5 different diseases. They all have a little bit way of causes that make them develop. They have all little fine aspects in how you treat them differently, and it's important to know that and differentiate these diseases as it makes up COPD. The model here is a common model that you'll see throughout healthcare and in even patients. The classic blue bloater on the left and the pink puffer on the right, and these two kind of stereotypes to patients actually will help you diagnose patients as you work with them. A lot of times patients come into the emergency department and even making up to the intensive care units needing quick and early interventions. These patients, when they come in, they're going to be very labored, work of breathing, very feel like they can't catch their breath, get any air in or out. And it's important in your initiation of management what you do. The baseline treatment that we always do is bronchodilators for these patients. So that'll be your albuterols, quick-acting bronchodilators. Give them, anywhere from 10 milligrams to even 15 milligrams or continuous, depending on the severity. The next thing that is typically influential in managing this in exacerbation phases is non-invasive ventilation in the form of BiPAP. BiPAP will help to stent the large airways where they have a lot of airway resistance. It'll help them get in and out deep breaths. It'll help to eliminate CO2. A lot of patients will be too far gone even after management with non-invasive ventilation. Their CO2 will be too high. When their CO2 is high, it makes them in a lethargic state where they can't manage their airways, and they'll actually need to be intubated and managed on a mechanical ventilator. Longer term, it's typically an inflammatory process where they'll need corticosteroids to help reduce the inflammation in their lungs, and this won't be effective for at least a day or two after the patient's been given corticosteroids. Antibiotics could be needed, and this is typically why patients go in COPD exacerbations, because they have increasing white counts. They may have an infection somewhere that causes this inflammatory response in their lungs and throws them into an exacerbation. For cystic fibrosis patients, they have in particular regimens in itself. When I worked at Indiana University, we specialized in the management of cystic fibrosis. And we used a wide variety of regimens to help manage and treat those patients. They would typically come in just like other COPD patients. We would manage them with non-invasive. They typically had MRSA infections at baseline. When you look at cystic fibrosis, patients have impairment of their mucociliary escalator, so they get pneumonias very easy. They need mucolytics to help break up the bonds and the secretions in their lungs, and long-term management through medicine, chest physiotherapy, and other things to help get them over the hump and recover. Long-term management of COPD can take a wide variety of aspects that need to be addressed before sending a patient off to pulmonary rehab or to home. Some of the things that we can use in the hospital is some quick educational pieces to display the importance of this and try to prevent the patient from being admitted back into the hospital. As healthcare goes on, reimbursement rates are looking at how often a COPD patient is readmitted to the hospital. a COPD patient getting readmitted to a hospital within 30 days is a big problem for a healthcare system. And actually Medicare and Medicaid are influencing reimbursement to those facilities that have that happen. And they see it as the hospital didn't set the patient up for success, or they discharge them too early, and they basically create kind of a fine in how they reimburse. The numbers that the Medicare and Medicaid look at are 30, 60, and 90-day readmission rates. Obviously, the further you go out, the more likely a patient is to be readmitted, but 30 days is the big one that they're looking at. Something we can do in the hospital is teach breathing techniques for when a patient is on the move or displaying shortness of breath, and that is pursed lip breathing, where the patient inhales through their nose and out their mouth. This method eliminates dead space, and it helps with ventilation of the patient. Ordering medications is another aspect of long-term management. So usually you have a rescue inhaler like albuterol. You have management steroids that is usually given twice a day, and they're longer acting to reduce inflammatory. You give them oxygen if needed, and then you basically treat them as they clinically present. So if they have pneumonia, they may have to continue with antibiotics for a period of time, and so on. Important factor that we can also do in the hospital is educate the patient on worsening condition, the signs of it. We can tell them what they're going to feel like when their oxygen drops. We can tell them what they're going to feel like whenever they start having wheezing and they can't catch their breath. We can teach them what they should do. We should teach them techniques of how they should do it, how they should take their inhaler. It's recommended to take within the spacer. You shouldn't taste it in the back of your mouth. If so, it's not depositing in your lung. These are all very important aspects of management for a patient, even at home. In the worst situations, patients should go to pulmonary rehab until they can manage themselves at their home. Flu vaccines and COVID vaccines are now at the forefront after the pandemic, but these are essential for long-term management of COPD since they're a risk factor for hospitalization for these patients. Typically, the cause and reducing the cause, so smoking, if we can get a patient to stop smoking, that would be great. And then social assistance. Some of these patients get admitted because they can't make doctor's appointments, or they can't afford their medication, or they don't have access to it. So social programs and helping them get the resources they need to make their appointments and get their medications is very important for the long-term management of COPD in these patients. Causes of COPD usually are from smoking. That's the biggest cause of COPD. And smoking typically usually steers a patient down the chronic bronchitis or emphysema pathway. Environmental exposures can do the same thing. And then for the others like asthma and chronic bronchitis, cystic fibrosis and those things, it can be hereditary. Some people are born with alpha-1 antitrypsin, 1% of people, deficiencies, and that can cause COPD. And some people are born with the genetic mutation to have cystic fibrosis, and that's something that they can't control. And so I would say 90% of this in the bronchitis emphysema is smoking, which could have been prevented. And there's about 10% of these diseases that cannot be prevented, and people are just basically inherently given it. For these patients, symptoms are pretty consistent across the board. They almost all of them experience shortness of breath, wheezing, shortness of breath with movement, They feel like their chest tight in extreme situations. They have a cough, usually productive with bronchitis and bronchiectasis. And the cystic fibrosis patients, the coughs aren't as productive unless they're doing their physical therapy consistently. The cystic fibrosis patients typically get lung infections, needing hospitalization. They lack energy because they aren't getting ample oxygen in their blood. A lot of times they have weight loss, especially in emphysema and fibrosis patients. And in the bronchiectasis or bronchitis, they can have swelling in their extremities. And these are not uncommon symptoms. They typically happen in most of these disease processes, depending on the severity or the acute process that's happening at the time.